Welcome to this webinar on Lynch Syndrome Awareness Day. It's some of the nurses from the Lynch Syndrome Clinic are also on this today as well. It's obviously a big day for us. We've been partying hard all day, but time for some more serious stuff now. So I've been asked to talk about Lynch syndrome with a focus on the gut, and other seminar has been organised which are more focused on gynecology and aspirin and other things. So I've deliberately steered away from those things. So I work at St Mark's Hospital in Harrow in London, and we have our clinic. We have about 600 people with Lynch syndrome. About 400 are under regular colonoscopic follow-up, and then we have several thousand other patients with a family history of bowel cancer who don't have Lynch syndrome. Our aim is to provide lifelong continuous care to people with a diagnosis of Lynch syndrome. We have a patient user group. We have a registry, so we know when people are due to have a colonoscopy. We know hopefully if they're taking aspirin or other things that are likely to help reduce their risk of cancer. And we're linked to a network of services, including specialist gynecology and dermatology and other things that will benefit people over their lifetime. And obviously with Lynch syndrome, we deal with a lot of families, and sometimes when people are referred, after the first person in their family diagnosed, they might have young kids, but this clinic has been going in one form or other since 1985. So some of those kids are now having kids themselves, and obviously of an age where they need to start to have colonoscopy or access other things to help protect them. So we manage people really and families over their lifetime, hopefully. We've also we have had funding from a charity called Fortitude, which is a relatively small charity, for 3 projects which are linked to cancer prevention, Lynch syndrome, which I'll mention during the talk. We're very much involved in developing national guidelines. So the guideline recommending that people with Lynch syndrome take aspirin, for example, and guidelines about gynecological or GI management of with colonoscopy, for example, in Lynch syndrome. And I'm just going to mention aspirin to cover it off. I think John Byrne is due to give a talk as well, so I won't spend too long on this, but many of you may have been in the CAP2 or CAP3 studies, but many of you may not, and CAP3 is finished recruitment at the moment. But what we know is that in the long term, if you take aspirin, you're half as likely to develop colorectal cancer. And it may have some benefit for other types of cancers, but that's not been proven. What we do know is that it reduces colorectal cancer risk, and that the benefit doesn't really occur for the first 7 years, because probably what aspirin does, it stops cancer development at a very early stage, and it actually takes quite a long time for a cancer to develop. Probably bowel cancer, an average bowel cancer takes about 17 years to grow from normal bowel. And there are different pathways. Some people can get bowel cancer more quickly, perhaps those with Lynch syndrome. It's not actually all that clear, but what we do know is that aspirin, if taken every day for 2 years, after a period of at least 7 years, there's a reduction, and the reduction is greater the longer after people have started taking aspirin. So we've now recommended this in NICE guidelines, and the longer term CAP data was published last year, and there's a trend that suggests that it may reduce the risk of endometrial cancer, but maybe partially because in the study so many women had a prophylactic or preventative hysterectomy. It was difficult to prove that in the CAP study. In CAP3, as many of you know, there are different doses of aspirin being compared. The initial reports from that study will be available next year, but really it probably won't be until the latter part of the decade before we know the best dose, because the benefit is in the long term, as I said. Linked to this, just going to skip past that, is H. pylori. So H. pylori is a bacteria in the stomach, so not in the small or large bowel, in the stomach, of about 30% of people in the UK. It's not specific either way to people with Lynch syndrome. So people with Lynch syndrome are likely to have the same, about 30% of people with Lynch syndrome probably have H. pylori. It's difficult to grow in the laboratory because it only exists in an acidic environment, which is what we have in our stomach. But what we do know about H. pylori is that it causes 95% of duodenal ulcers and 60% of stomach ulcers. And many people can have H. pylori, and because so many people in the population have it, most people won't have ulcers, but it does. Essentially, it's the main cause for most peptic ulcers. And if you take an aspirin, it's therefore good to have a test for H. pylori before you start and have treatment. And the other thing we know about H. pylori is that because the inflammation associated with this bacteria in the long term, it's also associated with increased gastric cancer risk. And we know that in an otherwise healthy population, if you test for H. pylori and treat it, you reduce the lifetime risk of people up by 35% of developing stomach cancer. And there's evidence from this study, this big Korean study of people with a family history of gastric cancer, demonstrating that the risk reduction is even greater, more than 50%. So H. pylori is an important thing to do. And unfortunately, endoscopy doesn't work the same way in the stomach as it does in the colon. So it doesn't prevent or identify the precursors to cancer in the same way as it does in the large bowel. Actually, having H. pylori testing and treatment is by far the most effective way to reduce your gastric cancer risk. There may be a role for endoscopy, but as of yet, has yet to be proven. I am going to talk a bit about the background to Lynch syndrome. If you take a step back for a moment, I mean, Henry Lynch passed away last year, but before Henry Lynch, there was somebody called Aldred Worthen. And this lady, Pauline Gross, who's a seamstress back in the early part of the last century, came to see Aldred Worthen, a physician in Michigan, and said, everyone in my family is getting cancer. I'm obviously concerned about it. This is her family tree, called Family G, after the surname Gross. And lots of people there are getting particularly gynecological cancers, but also cancer of the gut. If you follow this family tree over time, there is more bowel cancer in this family than there is cancer of the womb. So something has changed in the last 100 years, which may be the influence of our environment on our genetic risk of people with Lynch syndrome. But in Time magazine reported on this family in the late 1930s, and there were people, because eugenics was quite popular at the time, and this is the way of controlling genetic risk by, in a way that we would not consider ethical these days. People said that they should allow this line to die out because they had cancer and there was nothing that could be done about it, and obviously they were somehow genetically inferior. Fortunately, this is no longer the practice, but this is Henry Lynch, and he picked up this family again in the 1960s and similar families, and he started to see that probably until this time, until the 1960s, people thought that actually, even despite some families having a lot of cancer, that cancer wasn't caused by genetic factors. And Henry Lynch started to change the way people thought about this. And this is the same family. In the middle is the grandmother of this familial cluster, and she was the first woman to have colorectal and endometrial cancer and survive, because obviously surgical techniques had improved to the point where this was possible, anesthetic techniques and whatnot. So, and then more recently, this author, Amy McKay, is a member of this family and also a novelist who's written about her experiences of growing up in a family with Lynch syndrome. And this is a book, if you're interested, that you can buy on Amazon. It's a very interesting story that she tells. This is Henry Lynch a bit later on, and this is us in Newcastle in 2005 with the first international conference which brought together people in the US and Europe. And just before this time, we started to identify the genes that cause Lynch syndrome. This is the timeline of the history from family G, late 1800s through to the present day. And what we know now is that these people with a family history Some of them have Lynch syndrome and some of them don't. And we make a diagnosis of Lynch syndrome on the basis of a genetic test. It's a genetic diagnosis. It's not diagnosed on the basis of family history, although family history, a personal history of cancer, obviously gives us an indication as to who might have Lynch syndrome. We are obviously at St. Mark's very focused on providing high quality colonoscopy, and we would expect the same should be offered to people wherever they live. And it's obviously very nice to work in what some people might call an ivory tower, but actually it would be much more gratifying if almost the high quality colonoscopy that's available to people who attend a specialist centre was available in every part of the country. And there actually are solutions to this, which we are working on with the NHS at the moment. But if you have Lynch syndrome, then what we know is that colonoscopy is the gold standard exam. That we don't recommend CT colonography as a routine test or other tests. There may be a role for other things that help with colonoscopy, but colonoscopy should be the test that people have every 2 years. And the colonoscopy should be performed by people who do it very well. And that if a colonoscopy is not of a good standard, then it should be repeated within 3 months. So for example, if the bowel prep is poor, or if it's not possible to reach the entire colon, then it needs to be rearranged, and there needs to be a solution to the problem that meant that the colonoscopy was less than perfect. So as I said, we used to diagnose people with Lynch syndrome, or HMPCC as it used to be known, on the basis of family history. This is an Irish family from Galway, which is where I'm from. And lots of people in this family with the dark circles and squares have had cancer, and people with the dots in the middle represented in this family tree have had cancer outside the large bowel. So lots of cancers in this family, and we used to say this is a family which is high risk. But now we make a genetic diagnosis, and we know that this family, people with diagnosis of Lynch syndrome, which are about half of this family, have an MSH2 gene mutation, or pathogenic variant as is now known. So we make a genetic diagnosis. What do we know? How common is Lynch syndrome? Well, it's somewhere around 1 in 300 of the population. So it's not a rare disease, and things that we manage in gastroenterology, which is my specialty, like Crohn's disease and celiac disease, have a similar prevalence in the population. So it's a common disease, not a rare genetic disease. I think it's probably 1 in 300, not 1 in 100. I think that's probably maybe a bit of an overstatement of how common it is, but still 1 in 300 is very common. We know it causes about 1 in 30 cases of bowel cancer, and similar number of other cancers, similar proportion of endometrial cancer, but endometrial cancer overall is less common. And we also know that we only know about 1 in 20 people have Lynch syndrome. So unfortunately, most people who have cancer and who have Lynch syndrome are unaware of it. What do we do when we know someone has Lynch syndrome? Well, as you're aware, this has been slightly updated actually, but we recommend 2-yearly colonoscopy, which the age at which starts depends on which specific gene is abnormal. And it's been extrapolated that having colonoscopy regularly in this way provides people an extra 7 years of life. So it's obviously a tremendous benefit. Aspirin, I've mentioned, reduces the risk of bowel cancer by about half. But although it's a genetic condition, you can't do anything about the genes that you're born with. Having a healthy lifestyle modifies people's risk of developing cancer, even if you have a genetic condition like Lynch syndrome. So having a healthy diet and exercising regularly and having normal weight for your height have all been proven in people with Lynch syndrome to reduce risk of cancer. Obviously, it doesn't completely prevent cancer, but it might delay the diagnosis even if it doesn't prevent the cancer. And we know that from around the age of 40, women with some forms, but not all forms of Lynch syndrome, probably will benefit from prophylactic or preventative gynecological surgery. It's not the same for all genes which are implicated in Lynch syndrome, but it is for most. And then when people are diagnosed with bowel cancer or endometrial cancer, we might adapt the surgical approach in people who have Lynch syndrome. So we might think about a different type of operation, because that might provide some short and long-term benefits in people after diagnosis of bowel cancer. So, you know, people say that bowel cancer is actually not one disease, it's 5 different diseases, because bowel cancer arises via different routes and is responsive to therapies in different ways. And that's important because people with Lynch syndrome, or those who have tumors which are like Lynch syndrome, which is about 1 in 6 of bowel cancers, respond to some neuroavailable therapies in different ways. So, for example, immunotherapy with checkpoint inhibitors are increasingly available and increasingly important in people who have a diagnosis of a Lynch-related cancer. We also know that people with different types of genetic, pathogenic variants of genetic mutations, of which there are 5 actually, but the lifetime risk of developing cancer is highly variable depending on which gene is abnormal. So if you have an MLH1 or MSH2 gene mutation, then your risk of bowel cancer is considerably higher than those who have an MSH6 or PMS2 gene mutation. This is the largest available data set. It's not a perfect data set, but certainly there are significant, really significant differences in terms of risk. And I think we're thinking about this as something that we need to incorporate into a more personalized approach to care. So we have these are the guidelines which we published last year for the gene-specific management of Lynch syndrome, whereby we start colonoscopy at different ages depending on the gene that's abnormal. And that if people develop cancer, that we also think about how their surgery might differ depending on which gene is abnormal. So how do we identify Lynch syndrome and say if somebody does have cancer and there's only a 1 in 20 chance that they know they have Lynch syndrome already? Well, we developed the NICE guidelines in England, and I think Wales probably follows this to a large extent. It was published in 2017, and it states that everyone who's diagnosed with bowel cancer should have a test in the tumor for Lynch syndrome that tells the clinicians and them whether or not they should have a genetic test. And having an abnormal test in the tumor doesn't mean that someone has Lynch syndrome. It means that they need to have another test, which is usually a blood test, which is a genetic test for Lynch syndrome. So it's a slightly complicated pathway, but actually not as complicated as it looks. What we also know is that it's highly variable how this is implemented around the UK. There was a survey we did with Bowel Cancer UK, which was published a couple of years ago, and only about 1 of 4 centres are offering this to everyone who's diagnosed with bowel cancer. So 75% are not. And we know that it can be delivered at every centre, and we're very focused on trying to improve that. And this is Stephen Sutton, who some of you may remember. Stephen's father, Andy, has been a supporter of a campaign with Bowel Cancer UK as well, and has Lynch syndrome. And his son, Stephen, unfortunately was diagnosed with bowel cancer in his teens, but had been going to his GP and saying that he had symptoms and that there was Lynch syndrome in the family, and the GP said you're too young and didn't know what Lynch syndrome was. So part of the problem here is that GPs need to be equipped with the tools that they can provide people with Lynch syndrome the care that they deserve. And it's difficult for GPs because they only have probably 1 person with bowel cancer in their whole practice every year. And so the chance of them having someone with Lynch syndrome with bowel cancer is they probably have 1 every 30 years. So they don't encounter it much. Now you can inform GPs, but one of the things we're trying to do is actually empower patients to provide information to the GPs. We're working on some electronic solutions for that, but also with Lynch Syndrome UK, we have developed a patient passport, which hopefully will be available in the near future, which you can show to your GP and say, this is the condition I have, this is when I due to have my next procedure, I need to be referred, I haven't had this for 3 years, and that's not what should happen. After the NICE guidelines were published, we also had a meeting at the Royal College of Surgeons and published this letter in the British Medical Journal suggesting that we needed to develop a national registry, that people deserve to have good quality colonoscopy, and that we needed, with every cancer MDT, we needed someone within the MDT who knew about Lynch syndrome and similar conditions, and was able to ensure that patients with Lynch syndrome were identified and then received the right care on an ongoing basis. So this is one of the projects which is supported by Fortitude, and these are my collaborators, John Byrne and Amanda Cross. And John Byrne, for those of you who don't know, is the gentleman who leads the CAP studies, which relate to aspirin and Lynch syndrome. And Amanda Cross is an epidemiologist at Imperial College. And we have we will hopefully start to recruit to this. And the goal of this is try to ensure that there's as little variation in care wherever people are, if they're in Shropshire or Cumbria, Plymouth, or they're attending St. Mark's, that they all get exactly the same level of care. And then understanding when variation occurs, what impact it has, and what can be done to address that. So it needs to be used as a research tool so we can understand what we can do better. So moving on to talk about bowel cancer and Lynch syndrome. I've mentioned that people should have a colonoscopy every couple of years, but also it's very important that experience of the procedure and comfort is especially important if you have Lynch syndrome, or if you're anyone who comes for colonoscopy every couple of years. We want you to come back and want to come back. And so it is important that you have a good experience. And, obviously not everyone does, but then if that's the case, then there are different solutions to that. And we have to be systematic about how we address that if that's the case. But we do try and ensure that people do have a good experience. And there are lots of things that we can do to try and minimize discomfort. So we often do something called water exchange intubation, where we distend the bowel with water rather than with gas, and because it's distension of the bowel that often is the main cause of discomfort, and that is something which is actually particularly helpful. And some of you may have had water exchange intubation, and we use a lot of devices on the scope as well, which help, such as the endocuff or other assistive devices that help with intubation of the scope, and also allow us to get better views and identify more subtle polyps. So I'm just going to show you a video. This is, excuse the sound, this was a patient with Lynch syndrome at St. Mark's Frontiers meeting, which is a live endoscopy meeting. Here we go.
See, the GI genus also picks up what's clearly a blood vessel here as well.
So the GI genus is an AI device. So it uses artificial intelligence to identify what looks like polyps, and then you go and have a look. But it may be helpful. No? So actually, this is a polyp that I've identified.
Open it up, please.
And this is just.
I think for the non-endoscopists and perhaps the surgeons, I think it's a great example of the way that we can find these diminutive, tiny lesions and characterize them with zoom and narrowband imaging.
Close it up.
I think the discard strategies of.
Yeah. Oh, it's too late.
Yeah.
Was somebody going to query before?
I don't know.
Yeah. Okay, let's take it out. We've got the polyp trap on, yeah.
So we can talk about that little cuff of tissue. It's definitely
So that's it. That's the end of that polyp, and it's very tiny. I wanted to show you the other part of the video, maybe you didn't quite see, which is how subtle these things are. Can be very difficult to see. So just going to show you a little bit of this.
And
this is
see, the GI genus also picks up what's clearly a blood vessel here as well. You have to do your own lesion assessment. That's all right. Just using a bit of zoom here. I think just wondering if this is a little serrated lesion here. I'm just going to have a closer look. I think it's okay.
So here, this is a polyp right in the center, and it's extremely subtle, and we're using zoom. So we have equipment that allows us to use the endoscope like a a microscope.
And
And this is the kind of thing that we need to be doing in people with Lynch syndrome.
open it up.
We know that if you have regular colonoscopic surveillance, that even if you're unlucky enough to develop cancer, if the removal of these precursors to cancer doesn't prevent cancer, that most of the time we're identifying cancer at an early stage, and that makes all the difference in terms of providing people with options to improve the likelihood of surviving that diagnosis. But like I said, but despite regular colonoscopy, some people do get cancer. It might be related to the quality of colonoscopy, whether they're not having a colonoscopy every couple of years, or whether there's a biological process. So this is an interval cancer which is developed after a good quality colonoscopy before, probably because of a biological process, but this was a very early stage cancer. So this person had surgery and they didn't need any other therapy. We know that if you take biopsies, that what looks like normal bowel actually contains changes that might indicate that someone is at increased risk of developing cancer. And this is the mismatch repair deficient crypt foci, which are not present in people who don't have Lynch syndrome. We know that cancers can develop via 3 different pathways in people with Lynch syndrome. So one of the projects that we're working on, also supported by Fortitude, is we are taking extra biopsies from people who have Lynch syndrome at the time of the colonoscopy, because we wanted to see if you take a biopsy of a normal bowel, what looks like normal bowel, is there any feature there, any genetic feature within those cells, or any microscopic feature that you can't see with the naked eye, that will allow us to know who's at increased risk of developing cancer in the future, or who's at less risk. And at the moment, we perform a colonoscopy every 2 years. In some ways, we're hoping to find something early, but it may be that we can personalize people's follow-up more individually. And a few 10 St. Marks, and many of you will have participated in this study where we've taken extra biopsies, and thank you very much for that. One of the things that will hopefully come on the back of this is that we're working with a German pathologist. His name is Matthias Klür. He's also collaborating with John Byrne about developing a vaccine for people with Lynch syndrome. We know that the tumors in people with Lynch syndrome are different. They generate proteins that are specific to people with Lynch syndrome, and these proteins can be incorporated in a vaccine and have already been trialed in 26 patients. Although the vaccine isn't ready yet for the next kind of human study, because it needs to work a bit better, essentially. We expect that we'll hopefully be offering this in the form of a clinical trial in the next 5 years. And the information that we collect from these biopsies as part of this research study, we're using this data and collaborating with Matthias Klür to develop, to know which are the best proteins to insert into this vaccine. So so those of you who participate in the study are already directly contributing towards the development of a vaccine that will prevent cancer. The other project that's supported by Fortitude is a FIT study. Many of you will be familiar with the FIT program that we've developed during the COVID pandemic. FIT is a stool test. It's not something that will replace colonoscopy. It'll never replace colonoscopy, but it may be something that will help us decide when somebody should have a colonoscopy. And we use FIT in the National Bowel Cancer Screening Program for people who don't have Lynch syndrome, or anyone between the age of 60 and 75. Every 2 years, automatically receives an invite to do a FIT test, which is a stool test. And this is the probe for a FIT test. And if they have, what it detects is it detects blood, and that you can't see, so not visible blood, but microscopic blood. And if there's blood present in the stool, then somebody would be called for a colonoscopy in the screening program. So we wanted to know, do the precursor lesions, or do the cancers in people with Lynch syndrome, do they produce blood that will result in an abnormal FIT test? And this was the goal of our research project. But then everything changed last year, obviously. This is endoscopy activity over the course of, between January and May of last year. And as you can see at the outset of the coronavirus pandemic, there was a massive drop off in colonoscopy. And this was partially because staff were getting sick. Of the 9 endoscopy consultants in our department, I'm the only one who hasn't had coronavirus, and actually all of my colleagues got coronavirus within 2 weeks of the start of the pandemic. So we had staff that were sick. Secondly, we wanted to make sure that people who were attending for endoscopy weren't then catching it from staff, and so we had to develop systems to try and protect people. And many of you will have been through a process now of having colonoscopy and having a swab before you attend, and now staff are having twice weekly testing to ensure that if you do attend, if you're invited for a colonoscopy, that it's actually a very safe procedure. And coming to hospital for a colonoscopy at the moment is actually a very safe place to come. And if you're invited, then you really must take up that invitation. Don't be frightened because of coronavirus. You know, the risk is actually very low for having a colonoscopy now. But it took a while for us to develop this and for staff to recover from. Obviously, you know, we were at the epicenter of the pandemic in Northwest London, and at one point we had 1,300 staff off sick with coronavirus back in April, and now it's only about 200 to 300, so it's a lot better. But you know, these are obviously important issues that we have to try and identify what system we can use to protect patients when they attend hospital, and we're confident we've done that now across the UK. But at this time, you have patients with Lynch syndrome who are high risk, not being able to get their colonoscopy. So we repurposed our FIT study, excuse me for that, and we developed a national service whereby clinicians could request a FIT test and for their patients who they knew had Lynch syndrome. And if they did, they would send us a request form, and we would send a FIT kit, and then we would return the result to the clinician. The clinician could use this FIT kit result to decide whether somebody needed a colonoscopy urgently or not. This is a 41-year-old lady who had a normal colonoscopy in 2018. In 2020, she declined because she was concerned about coronavirus, and she was happy to have a FIT test. The FIT level was raised well above the threshold of 10 that we would recommend an urgent colonoscopy. She agreed to colonoscopy and was found to have a polyp at the hepatic flexure. This is it here. I think you can all probably see that. And that's it. We've removed it, and it's a what's called an adenoma with high-grade dysplasia. So it's an advanced precancerous change, and it's fortunate for her that she was able to access this FIT test. What we don't know though is FIT. You know, it was sort of a almost like an emergency program during the coronavirus pandemic, but now colonoscopy services are up and running, and we have to really decide in the long term, is FIT the right thing to do for people with Lynch syndrome, to try and risk stratify those into those people who need it urgently and those who can wait for a few more months. We don't know that. Or can FIT be used if you're having a colonoscopy every 2 years? Can you have a FIT every year? And if your FIT level is raised in the year between your 2 colonoscopies, should you have an additional colonoscopy? So we have just received provisional ethical approval for the FIT study, and we should be opening this around the UK in the near future, and we'll be inviting people to participate in this. And essentially what will happen is what I've described, is where you have a colonoscopy every 2 years. Every time you have a colonoscopy, you'll have a FIT test before, and we'll then look at the colonoscopy and see if the FIT predicted an abnormality. But also in the year between your colonoscopies, you'll have an extra FIT, and if that FIT level is raised, you will be able to access a colonoscopy. So we want to see whether or not actually that's a useful thing to do or not, and we're not 100% sure. Otherwise, we wouldn't do it as a research study. We'd roll out as a service. But it's an important thing to know about, and may benefit a lot of people if we get it right. So I mentioned that we adapt our surgical approach. So we know that if you have a bowel cancer and you have a segmental, so a limited resection of the bowel, that after about 9 years of follow-up, there is a 1 in 4, 1 in 5 chance that you may get a second cancer in the bowel. So we now recommend that we consider, and people, especially those with MLH1, MSH2 gene mutations, have a bigger operation to help reduce the long-term risk of bowel cancer. And then when people are diagnosed with bowel cancer, we know that about 1 in 30 will be due to Lynch syndrome, about 1 in 6 will have tumours which are like Lynch syndrome tumours. And that these tumours, but people with Lynch syndrome, or those which are like Lynch syndrome tumours, respond differently to chemotherapy. So 5-FU, which is the mainstay of chemotherapy, does not work as well in Lynch tumours. And oncologists will use this test, this initial test in the tumour, to decide sometimes where the benefit is thought to be really marginal, whether it's actually worth the toxicity of chemotherapy. And secondly, we know that people with Lynch syndrome, there's a different type of chemotherapy, well, not chemotherapy, immunotherapy with checkpoint inhibitors. And it's only people with Lynch syndrome and those who have Lynch-like tumours who respond to immunotherapy. And some people respond extremely well. And you know, I'm very glad that people can access this now, because it actually makes a huge difference to people with Lynch syndrome who have been diagnosed with bowel cancer, where they're, you know, perhaps where the option of upfront surgery is not possible. This is the study which demonstrated that mismatch repair deficient tumours are the Lynch or Lynch-like tumours. The people are much more likely to survive for many more years than they would have previously because of this new immunotherapy. So thinking about what's in the future, what we want to try and address the variation in colonoscopic quality and follow up is we're working on this with NHSE at the moment. And we've been actually working on it for many years, but there's a lot of interest in this at NHSE at the moment. So not NHS England, and it's obviously different in different nations in the UK, but people will be having colonoscopy if they have Lynch syndrome via the bowel cancer screening programme, which will ensure that the bowel cancer screening programme is, in my view, the NHS at its very best. People get fantastic pre-procedure care, they get great post-procedure care, and they get the procedure done by really good colonoscopists who have to pass special driving tests. There are additional staff in the room, and patient experience is extremely important. And this is the service that we want to provide people with Lynch syndrome. We also want not 25%, but 100% of people to perform testing for Lynch syndrome after diagnosis of cancer in the UK. We want there to be a lead in every MDT, and we want to develop a national registry. And just like to finish up, I want to show you this slide. So Menna Hawkins is one of the nurse specialists in the Lynch syndrome clinic. And for her MSc in genetics and genomics, she's asking people about their experience of having genetic counselling. So if you want to scan the QR code, or I'll leave this slide up for a minute. If you wanted to take down the web page, then it doesn't take even 10 minutes to complete this survey. So we'd be very grateful if you would consider completing this, so that we can learn a bit more about what the experience of having tested for Lynch syndrome is like for people, including those who have Lynch syndrome. So that's the end of my talk. I'm just going to see, I don't know if there are questions on the chat. Somebody's raised a hand. I'm just trying to get back to the other screen. 1 second. So, okay. So there's a couple of questions here. Tracy, is it hope that Lynch syndrome clinics will be across the country in the future? So what we want to do is develop a national network of expert centres. And there are, although we have a Lynch syndrome clinic, which is focused on kind of lifelong care, there are other places that provide very good care for people with Lynch syndrome. You know, for example, in Manchester, there's an exemplar, in Edinburgh, and places like Birmingham that are trying to develop and provide a good service, and others. Now, they're obviously maybe the focus in a slightly different way. But what we want to do is develop a formal network whereby every cancer MDT, so if you're in a little hospital somewhere in, down the road, that your experience is exactly the same as if you're in a major center, because the clinicians in that cancer team have a way that they can ask for advice from an expert center, and those links need to be formalized. So what we were working towards that there are 7 national centres in England, and obviously additional centres in Wales, Scotland, Northern Ireland that are linked to the expert centres, and that every cancer team in every hospital in the country has someone who is interested in trying to provide a good service. Second question is from Hannah, who has I'm just reading this, sorry, reading it aloud. MSH2 gene mutation. None of the women have had an endometrial or ovarian cancer. Is this a coincidence, or could that risk be lower? Well, I think it's the short answer is that probably is a coincidence, and you know, there are exceptions, however, you know, although PMS2 is associated with a very low risk of ovarian cancer and a much lower risk of endometrial cancer, there are some families where endometrial cancer, for example, is, you know, clustered in a family with PMS2, and so, you know, you have to tailor things, you have to personalize things to an extent, but overall, if, you know, within a family like yours, Hannah, I would still suggest that you consider, for example, a preventative hysterectomy. Although it's not the only thing that needs to be considered, there are other options, and I think that, you know, if you're speaking to a gynecologist, one of the things we know is that endometrial cancer often presents at a very early stage, and that vigilance for symptoms is extremely important and actually can be very useful. There are no checkups like having colonoscopy for endometrial cancer. So, you know, we don't recommend surveillance, and that's why we recommend preventative surgery, because there are no checkups that are effective. But also we know that preventative surgery for gynecological organs probably doesn't actually, as a preventative measure, doesn't really add much benefit before the age of 40, and that's based on the latest published European data. So I think in your 40s, if you have an MSH2 gene mutation, you should have a discussion about whether or not you should have preventative hysterectomy, or if you should consider other options. And there are other things, and there are progesterone contraception may be associated with lower endometrial cancer risk, for example. So I think if you're speaking to a gynecologist, and they may say to you, do you want an operation or not? Actually, the question that you should be asking is, what are my options? What are the alternatives? And try to have almost force them into having a balanced discussion, because although some gynecologists will provide that reflexly, many gynecologists won't know much about Lynch syndrome and think that having preventative surgery is all there is to it. The next question is from Caroline. It's about H. pylori. So why is a one-off test advised, not repeated tests? So the reason is that what we know is that if people just do it once, then the long-term risk of stomach cancer is reduced. It's not a screening test. It's about reducing the inflammation associated with H. pylori in the long term. So the only reason that we suggest people have a retest is that if you take a step aside for a moment, so H. pylori, every GP knows about H. pylori because it is so common, because it's associated with peptic ulcers. And if you are, an average person, you go to your GP and say, I've had indigestion for a few weeks, before your GP refers you to hospital, they have to do a H. pylori test, because for the vast majority of people, that indigestion is caused by H. pylori. And if you have H. pylori, you can have a poo test or blood test or whatever, but there are lots of ways of testing for it. Then after a week's treatment, then H. pylori is gone and those symptoms resolve. And most people don't need to have an endoscopy in that situation, and can avoid having an endoscopy. So GPs know about it. Now, if you have indigestion and you have Lynch syndrome, you need to have a lower threshold for investigation. So if you have new symptoms, then you need to discuss them with your doctor. But we know the evidence is clear that having a test once in your life reduces the long-term risk of gastric cancer. And it's not like having a checkup, because it's not a cancer screening test. It's about reducing inflammation in the long term. So it's not like having a checkup, like having a colonoscopy, which needs to be done regularly. And then a couple more. So Tracy again has asked, how experienced is the person doing your scopy? My dad had to go through prep again to get polyps removed. As I said, they weren't experienced enough. Yeah, no, I mean, obviously going through prep for many people is the worst part of the experience. Obviously having good bowel prep is really important. I mean, I would say in most hospitals at the moment, people with Lynch syndrome and anyone having a colonoscopy, most hospitals struggle with to try and meet the people referred on the suspected cancer pathway and or people with routine symptoms. They're by far the biggest workload for hospitals up and down the country. And sometimes people with Lynch syndrome get a little bit forgotten about in this process, because the things that are performance managed by the NHS are the 2-week wait pathway and the routine pathway, and the X percentage of people getting through this pathway in an effective period of time. So people who are having regular checkups with Lynch syndrome or inflammatory bowel disease, which is another high risk condition, they don't get picked up and they don't get monitored by the NHS. And this is a bit of a problem. Now, mostly hospitals struggle to meet those demands, and the demands of endoscopy increase year on year. So people tend to go on any sort of a list, and it may not be the most experienced colonoscopist. Like I said, what we want to do is to get people through the bowel cancer screening program. If you're a bowel cancer screening colonoscopist, you have to sit what's called a driving test. And this means that the quality of your colonoscopies, as judged over hundreds and hundreds of procedures, are consistently at a high level, that you're very good at detecting the precursors to cancer, for example, the polyps. So your polyp detection rate must be high, and you should be able to reach the entire colon over 95% of procedures. We want that's what we want, because actually, I think you're right. I think Lynch syndrome, because of the risk of cancer, it is higher. It's higher than it is for people referred with suspected cancer symptoms. It needs to be done by someone who's very good at it, and that's the long and short answer. Mark, sedation seems to get less and less every scope. People are comfortable, they feel better going to the scope. I've asked and been declined more sedation. So I think that whatever it takes for people to feel like that it's been a tolerable experience. It's obviously not never going to be an enjoyable experience, but or it shouldn't be. It's got to be a tolerable experience, and that means that if you need to have more sedation, you have more sedation. There is a point where if you have a lot of sedation, that it can cause your breathing to slow down, and that's why you have your oxygen monitor the whole time. So there's a limit to how much sedation people can have safely. But at the same time, we actually probably do use small amounts of sedation, because people are getting, overall, compared to 20 years ago, people in the UK, people are much better at colonoscopy, vastly better, because it's been a mass improvement process throughout the UK over the last 20 years. So everything about colonoscopy is better than it was 15 years ago, certainly vastly better than 20 years ago. And one of the things that 20 years ago, people used far too much sedation, and there were lots of people who were ending up with problems because of over sedation. So we know that we can do it with less discomfort and more safely now. So there is possibly a trend towards using that sedation, but I think that whatever procedure you're having, it needs to be something that you feel like you're going to be prepared to come back in a couple of years. And so having a procedure that's right for you needs to be treated very seriously. Mark, about Diet Coke prep, honestly, I don't know much about it, but I've seen a little bit on Twitter, and that's all I can say. So you probably know about as much about that as I do. But I think if you are going to take bowel prep, then Diet Coke with your bowel prep, it's probably worth just discussing it with the nurse in the endoscopy unit who you can talk to about your bowel prep before your procedure. So Debbie has MSH6, had a right hemicolectomy in 2015. So she's asked about after 9 years should be looking at further surgery. No, so that's not what I'm saying. Just to be clear, it's that a right hemicolectomy is a very common procedure in people with Lynch syndrome, because people are more likely to have right-sided cancers with Lynch syndrome, and because they are biologically a little bit different from other bowel cancers. So having a right hemi is not unusual. If you know about Lynch syndrome and you're having an operation, you may have a bigger operation than a right hemicolectomy. What I would say, that if you've had a right hemicolectomy, almost certainly it's you've had a very good operation. It's, we're 6 years on now, which is great. Congratulations. Colonoscopy is getting better. If you take an aspirin, that will halve your risk of bowel cancer again. If you're having colonoscopy and you have it regularly and it's of good quality, that will reduce your risk of bowel cancer further. So not having had a big operation is something that I wouldn't worry about now. It's just something that is worth thinking about at the time of your diagnosis of cancer. So the key thing is that you think about whether or not you can take aspirin, and you have that discussion with your team, and that you have a good quality colonoscopy. So Yorkie, the hardest thing is getting past GPs. So after a difficult experience, surgery now is a bit better. Yeah, I think it is important. Like for the reasons I said, it's difficult for GPs. I do have sympathy with them because they've got to know about a lot of different things, but it's a problem. And I think that with the patient passport, if you can go to your GP and you have something written down, something official, and then actually something the GP will kind of think, okay, and then maybe on that passport that we've developed, Tracy might know where we are with that, if people can access that now or not. But you can use that to negotiate with your GP. So empowering patients is an important part of that, and continue to inform GPs, of course. Shelley, anyone having a colonoscopy, can't do the whole bowel, never repeated. What about those curly whirl bowels that prevent the instrument getting past the join? It needs to get through into the colon. It doesn't need to get into the small bowel necessarily. And some people do have technically difficult colonoscopies, but we're obviously a lucky centre in that we're kind of national endoscopy centre, and we have lots of good equipment. But we have things like double balloon colonoscopy, whereby the difficult colons can be negotiated with a double balloon, and it's also associated with less discomfort. So sometimes people can't have a colonoscopy easily because they have a twisted, well, not twisted, but a narrow bowel. Then there are alternatives, and then we have to be systematic about how we approach problems like that when they arise. Yorkie C has asked again, from my scope, I always seem to have a consultant on the second monitor, and Derriford are superb. Registrar scoping me, only gas and air. Yeah, I mean, many people are very happy with gas and air, and actually they prefer not to have too much sedation, because if every couple of years maybe you don't want to have sedation and actually you find the procedure tolerable. The experience is highly variable, and probably we are doing more with gas and air. It's, for those of you who don't know, nitrous oxide is a short-lasting pain relief. It's not sedating. It means that you can go to work, you can drive afterwards, and if for many people the bowel prep is worse than the colonoscopy, and the colonoscopy isn't too bad, and gas and air is an adequate way. So Tracy says, oh, so these passports are all ready to go, and she has a batch ready, and to contact Lynch Syndrome UK if you'd like to have a copy of that patient passport. So that's the last of the questions, I think. So yeah, thank you very much for joining. I've got to go put my kids to bed. I'm sure you've got stuff to do as well. I know that there are other seminars, other webinars that are being set up in the next few weeks, and I think this has been recorded. I'm not sure, but Delia might know. I think just organised this. So, but otherwise, I wish you all the best. And I don't know if it's a greeting that we're supposed to say, but happy Lynch Awareness Day. And I hope that you're all well. And thank you for joining today.
Thank you, Kevin. Really appreciate it. And yes, it's been recorded. Okay. So you go get those kids up to bed and read them a lovely story.
Thank you very much.
No pressure. Thanks a lot. Thanks, everyone.